Good afternoon. I'm very grateful to Robotic Surgery Collaborative for this kind opportunity to come and present some work today. It's an absolute pleasure and honor to talk to you. I've been given the talk about how to build a successful and impactful robotic colorectal program, and I will hopefully share my experience and my journey with you guys over the next 10 to 13 minutes. My background is colorectal surgery. I specialize in rectal cancer and CME surgery, and my areas of interest are obviously robotics. We have run a successful robotic TME training program for some years, and overall I have a decent experience in minimal access management of rectal cancers. When I was thinking about this talk, I was thinking how to define success in colorectal, and I think success and impact are two very powerful yet very subjective words. How would a successful program in robotic colorectal look like? And I think these are the ideas I could come up with, that you have to have good clinical results, like good outcomes for patients going home in time, length of stay, complications, reoperation, conversion rates, and then good oncological outcome because you're dealing with cancer patients. So low local recurrence, improved survival, all those sort of things. Better patient experience with better quality of life for those patients. And above all, in the present day and age, we have to run a very cost-effective program because money is always an issue. You have to have some academic collaborations and achievements in terms of publishing your successes and results. And then above all, enjoy that journey alongside your team. When I look back at our own results, I can share with you that it gives me pleasure to say that we managed to reduce our length of stay dramatically by converting from open into laparoscopic and then from lap to robot. We reduced our elective mortality and morbidity rate dramatically to less than 1%. Portsmouth had the lowest mortality rates in the UK for elective colorectal cancer, which was 0.5% for all comers. And as you can see on the right-hand slide, there's a decent mix of lap and robotic program with over half of the cases done robotically in elective colorectal cancer surgery setting. Very minimal open operations are being done. This is not the situation across the world. As you can see, even within the UK, over more than 45% of rectal cancers are done open. The situation is even probably worse in the US. And whenever they're attempted laparoscopically, there is a high conversion rate. And when you're looking at robotics, you're looking at the implication that where you can use the technology. And I think the best focus will be cancer surgery, and TME or a CME for colonic cancer or rectal cancer would be the ideal indications. Similarly, for benign disease, I would think that diverticular mass and complicated diverticular disease is a great indication for a robotic approach. Pouch surgery for nerve preservation in young people is again very, very attractive. And rectopexies, for example, ventral mesh rectopexy, where suturing can be technically challenging in the pelvis, robotics simplifies that. And if you're pushing the boundaries, you can think of lateral pelvic lymph node dissection. You can have indications for multivisceral resection for beyond TME cases that we normally participate in. We know that robotics does offer you a stable platform. It offers you a high quality 3D vision with endo-wrist instrument, giving you the flexibility and scaling down so that you can operate in a safe fashion within that avascular plane without getting into any bleeding. All of this will translate into better dissection. And importantly, the nerve preservation for the patient, resulting in better sexual and bladder function and bowel function, but importantly also prevention of stress-related injuries to the surgeon. If I look at Portsmouth data, we can split this into mainly rectal cancer, having anterior resection or APR, and then right hemicolectomies, which are mainly, majority of them, complete mesocolic excision of the colon, and then some benign indications, which were IBD or diverticular disease related. This slide just summarizes our experience in my unit with lap TME and robotic TME over the last 10 years. We had decent outcomes from laparoscopic TME with a low conversion rate, APR rate of 11%, and length of stay of 7 days median for all comers. The major complications were low, and operating times in general for 4 hours. When we adopted robotic TME, we were not sure how much benefit we are going to see, but we definitely saw improvement in outcomes across the different domains. There was no conversion in our robotic series. We had reduced the stoma rate by 3% in permanent stoma rate, and length of stay was reduced by 1 day. Obviously, major complications and morbidity also improved. We looked at survival for these patients, looking at mid to long-term survival, and we compared laparoscopic and robotic TME patients having rectal cancer surgery, and even propensity matched them to take away the bias from staging and cancer presentation and the follow-up that we had for these patients. And we were interested in looking at the factors that will affect survival in these patients, and the univariate analysis did highlight conversion was a factor, grade 4 and grade 3 complications were definitely contributing to survival. But more importantly, what we found was that robotics was again a big factor in improving overall and disease-free survival for these patients. So robotic TME patients had an uplift of 20 to 30% in their survival at 3 to 4 years follow-up, both for overall and disease-free, which was statistically significant. Now that's a very strange finding in a sense that you have the similar kind of operation, but you're getting much better improved survival long-term for rectal cancer patients. And what are the causes behind it? It could be better dissection, better lymph node resection, less complications, earlier return to adjuvant treatment, less stress response, because that's all areas that we are actually kind of doing more research into. But we are not the first one to report this. Similar findings were found by Professor Aguilar's unit from MSK and Professor Kim from Korea, who found that robotic TME was an independent factor for overall survival of these patients. I call these marginal gains. You're improving outcomes in different domains with small percentages, but when you add those aggregate gains, you get a big improvement in patient care and their journey throughout their care. And the main domains where we have seen improvement is avoiding stomas, reducing leaks, reducing the ITU admissions, reducing conversions, and reducing the need for extra adjuvant treatment. When you look at some of these domains across and you try to quantify what impact they have financially, it is quite a startling discovery, because you can see, if you're looking at the complications in laparoscopy, the blue bar, and robotics is the light blue bar, where you can see the drop from 22 to 16%, the length of stay drop from 7 to 6 days, conversion rate 5 in lap, none in robotics, and the readmission rate was low in robotics as well. And similarly, the clinical major leak rates going back to theater were low in the robotic arm as well. So when you start putting a monetary value to all of these and you start adding it up, you can easily quantify the impact, the total impact of this over the healthcare system and the cost to the department and the unit and the trust. And when I compare my own data with the open and robotic Da Vinci cases, you can see over £8,000 savings. And similarly, between lap and robotics, you can see over £2,700 saving in those cases. We opened up these cases in theater for lap anterior section, and we thought we'll just do a kind of a costing for those. And you can see £962 for these. And in robotics, we opened up the standard 3 instruments, and we cost about £1,100 in theater. And so head-to-head difference is no more than £200 between lap and robot. And the domains I showed you before, if you try to make savings across those by reducing length of stay, ITU, stoma rates, and so on, you can, in a calendar year, with a model of 100 rectal cancers, save over £280,000 in a calendar year. That's a substantial amount of money that you can save. Now, people may ask that there's a cost to the robot, there's a cost to the maintenance and capital cost. You have to factor those in. And if I could just borrow a leasing model for a robot per day with £2,000 per day use, I could still do 50 rectal cancers for 100K, which means that in the end, I could still end up with a saving of over 180K in a one calendar year with the 100 rectal cancer model. This is the simplistic way of looking at the cost that you're spending upfront and the saving that you're making in the short term. Now, this is hot off the press. Intuitive have recently contacted their high-end users and informed that they will be looking at the usage of these instruments, and they're trying to improve the number of times instruments can be used. Obviously, there's a balance between using an instrument that has to still perform well, but at the same time, reducing the cost of these instruments by allowing more uses of these instruments. That number will be variable between, at the moment, 10 lives per instrument, but that will be between 10 to 18. I think the number is going to increase, and it may depend on the type of the instrument and its usage. But overall, the prediction is that that will have a significant impact on the cost. For an LAR or a right hemi, for example, in Portsmouth, we predict that there will be over £250K reduction in cost per procedure on those fronts. Now, how can we build a program like this? When I look back over the last 8-9 years in the journey, I can share some points with you where we have seen definite improvement and outcomes improved, and the lesson that we learned in that journey. I think the standardized technique is important. You have to have a proper training and adequate mentoring and stick to that technique. When we started it, we had dry runs with teams of practicing robotics and how the docking is going to happen, where the port placement and the room layout is going to be, and the patient positioning and all that. And that repetition And standardization is the key to reducing your operating times, improving your team performance, and getting the best results. The docking time should be no more than 5 to 10 minutes when you have a very well-functioning, experienced team who knows what they're doing. And then standardizing your technique, use a standard set of instruments. We have bipolar, fenestrated carrier, or double fenestrated, and a hot shears. And then you have a standardized technique starting on the sacral promontory, finding the IMA, protecting the nerves, going to the higher region of IMA and ligate it at that level. And this is a surgery performed in avascular planes. It's a beautiful operation to perform. You can see very clearly without a drop of blood, and it could be a very good training opportunity for young residents and fellows who are trying to learn this complex procedure. Obviously, the nerve preservation for these patients is the most important thing in my view, and I have a specialist interest in that. I think the robotics allows that to happen because you can visualize things much better and hence perform surgery in a better fashion. You do have extra instruments available if you need to use them, and we do selectively use them based on the complexity of the case. You have a vessel sealing device, stapler, and double fenestrated grasper. Again, a little bit of TME at the back. You can see the angel's hair kind of at the back where the mesorectum is joining with the Waldeye's fascia. And this is opening up of this areolar plane at the back, which is the first step in starting the TME dissection of the pelvis. And you can see this operation is actually between the right and the left hypogastric nerves. And the surgeon should learn this first, going as far back as possible. Back dissection is relatively easier. It's the anterior dissection, which actually is much more tricky and difficult, but the robot actually makes that view really, really clear. And the access with the endowrist instruments is phenomenal, where you can dissect between the two layers of the non-medius fascia, either in front or behind, or within the two layers. And obviously you protect the nerves around the seminal vesicles at the anterolateral corners, and you can also protect your CRM. Now, high volume practice is again important. You need to be performing this repeatedly. If you perform only one case a month, it's unlikely that you're going to get over your learning curve very quickly. So having a regular attendance in the OR at least once a week and performing robotic procedures is the key. We published on this before that if you have a good, high quality, high volume laparoscopic practice and you transform that into robotics, your learning curve is no more than 10 to 15 cases. But the key is to perform it regular enough. Have a prospective data collection. I think this is very important that you know from beginning what data fields you're going to be collecting. You have preferably an independent data analyst who can record that data for you, unbiased and accurate, and you ensure that it is safe, accurate, and up to date. As I mentioned before, academic collaborations are important. Things like sharing your success stories and learning from each other and mentoring and helping each other out is always a player. You can publish as you go along. We did on the different aspects of robotics and cancer surgery, rectal cancer high-risk surgery here. We saw improvement in outcomes for patients from having robotic procedures in high-risk cases. Stapler, we saw definitely improvement in the use of robotic stapler with less firings as compared to use of laparoscopic stapler, translating into better outcomes. And there are various publications that we have published that if you're interested, please have a look. But when you are performing high volume surgery and sticking with the technique, you're bound to get experience along the way, which you can then share with other colleagues. So I'll leave that for you to have a read through yourself. And lastly, I will stop by saying that the most important thing not to forget and underestimate in this situation is team building. You have to have a good team supporting you all the way through. And this is not one man show. You have to invest in developing and building those relations and those teams and colleagues with you, and in all fronts support them as you grow. So I will leave you with this thought that robotics is here to stay. I think it is a precision tool which gives you a chance to perform surgery in a much controlled and much better fashion. And a good program will evolve at the back of good standardized technique, sticking with the basics and repetition, data collection, and team building. Thank you very much.